inform us through their talks. I invite Dr. Venkatesh Sugandaraj. He is at present the medical director of Dr. Agarwal's Hospital, Crompet, Chennai, and he has served in several prestigious institutions and is an eminent innovative phaco surgeon. Welcome you, sir.
Thank you for the invitation, Doctor. So I'm going to show you a 10-minute video clip on certain changes I have made in the direct phaco chop. So I am a direct phaco chop surgeon, and I'm going to show you today the various changes that I've made in various grades of cataract. To take the soft cataract, direct phaco chop is not the technique of choice. Let me point out, a large rhexis, hydroprolapse, or a hydrodelineation and prolapse is probably the best technique. But if you end up with a smaller rhexis and delineation is not possible, then you can try what I call the soft chop technique. And the secret in the soft chop technique is essentially in the settings. So what we do is you impale the nucleus with low power. So power of only 20%, an aspiration flow rate of 100 and a vacuum of 100 millimeters of mercury. Now once you have held the piece, then increase the vacuum to 250 millimeters and then create the chop by scoring on it. Sorry, aspiration flow rate of 10 cc per minute. So once you do this, you can use the sharp chopper and crack this soft lens like a cake. So the secret is you bury with low power and low vacuum. Then you increase the vacuum to increase the hold, and then you can chop with a sharp chopper. And you can see that with this technique, it's quite simple to create the direct chop even in soft cataracts. Normally, we suffer from a lot of crater formation, and this is because we're using high vacuum and high power in these cases. So you have to use low vacuum and low power, and once you hold the lens, there should be no power delivery at all, only vacuum to hold it, and then you have to chop. Very soft cataracts can be held with vacuum alone and chopped. This next, we'll move on to small pupil, where I think the direct phaco chop really scores. Now, in this small pupil, of course, the challenge of small pupil is overcome when we use hooks or rings, but in this case, I'm going to perform the small pupil phaco without hooks or rings. The trick is, or the critical point here is to get as large a size of capsular rhexis as possible. So you have a pupil hugging capsular rhexis, or you can just carry the edge of the rhexis behind the pupillary margin. This is of great importance because the rhexis size will control the rest of your phaco. Then the cortical cleavage hydrodissection is a must. If this nucleus does not rotate, then you cannot perform phaco. Then you see that the whole procedure of direct phaco chop, its great advantage is you can stay within the central 2 millimeter of the nucleus, that is in the central 2 millimeter of the pupillary area, and perform the chop and all the disassembly procedures. Having driven the phaco tip in with sufficient amount of power, say 30%, and a high vacuum of 300, you hold the piece and then you can just chop these pieces. And remember that when you're dealing with smaller pupils, there's also a smaller capsular rhexis size. So you have to create as many small fragments as possible. If you just create 4 fragments like your stop and chop technique, then it won't be possible to mobilize these nucleus fragments because the rhexis is small. So multiple smaller pieces have to be done. So I generally do about 6 to 8 fragments before I attempt mobilization into the central space. In fact, I found that some of the clearest corneas I have got in the post-op period is when I've handled these small pupil cases, because the smaller rhexis size, not the pupil, the smaller rhexis size that is dictated by the small pupil size will force me to create smaller fragments, which means only one piece at a time is mobilized into the anterior chamber. The rest of the nucleus remains within the bag. You don't have lots of nuclear fragments floating and buffeting against the endothelium, which is propagating damage to the endothelium. And because of this, this feature of just one piece at a time being emulsified in the central safe zone, I find that some of the clearest corneas I have got when handling direct phaco chop in small pupil cases. Now, so how do we prevent certain damages, like when you're trying to chop? So if you're trying to chop with a sharp tip chopper and you have to take it to the mid periphery to chop, then you place the tip of the chopper on the lens itself. Now we move to grade 2, and today my go-to technique is to create a capsular exercise of just around 5 millimeter or less. And this adaptation I adopted after seeing the results in my small pupil cases. So I figured that if you keep the rexus size small, it will control the rest of the procedure, that you are forced to create smaller fragments. The entire lens remains within the capsular bag while you mobilize the smaller fragments into the anterior chamber and remove it. And this is the reason why in grade 1s and grade 2 nuclear sclerotic cataract, my rexus size is about 5 mm or just below 5 mm. In denser cases of cataract, I would use a 5.5 mm capsular rexus. Now you see that I am taking the sharp chopper. This is a Mohanrajan chopper. I'm using a 1.75 Mohanrajan chopper. And you see that I'm not chopping 1 millimeter in center of the in front of the hold. I'm actually going to the mid periphery. It makes a lot of sense to crack the nucleus in the mid periphery because the lens is thinnest there. The lens being spindle shaped is very thin close to the periphery. The crack will immediately happen and the crack separation also will occur. If you are scared that you'll actually nip the rexus while carrying it there, the simple thing is to place the tip on the lens surface and then drag it to the periphery. This way you will never damage the edge of the capsular rexus. Only if you lift it and place it in the periphery will you damage the edge of the rexus. If you slide it along the lens surface, it will just push away the piece because it's got a blunt end. And then finally, after cortical aspiration, when I put in the intraocular lens, you see that there is a fantastic overlap of the rexus margin over the IOL because it's a sub 5 mm rexus. Even if it is slightly decentered, it will work. There is something called mid-peripheral chop I'll be using in harder grades of cataract. Look at this cataract. This is a grade 3 to 4 nuclear sclerotic cataract, and this is a change that you will see. I'm chopping from the peripheral portion and see how the chop happens like a hot knife through butter. So what I did is I took the sharp chopper, slid it along the surface of the nucleus till I reached almost the peripheral portion, and I initiated the crack and chop and separation from close to the nucleus peripheral location. Now, this we all know is like a horizontal chop, whereas a vertical chop is done more centrally. So this is why I call this technique the combo chop, because you're combining the horizontal chop with the direct vertical chop. What is the advantage? In a horizontal chop, the forces that help to break the nucleus is a compression force as the nucleus gets trapped between the peripheral and the central instrument. It compressed and cracks. Whereas when you're using a direct vertical chop, it is what is known as a chop force or translation force that splits the lens. So when you do this combo chop for harder grades of cataract, you will find that the crack and separation happens with greater efficiency. Another simple tip I want to tell you is that if you want to get clear corneas, you should be very careful to control the plane at which you emulsify. This is the safe zone. The supracapsular zone is the safe zone. But if you emulsify close to the endothelium, it's the unsafe zone. How will you know it? If we are using a standard 30-degree bevel tip, and if during phaco the bevel is visible to you, it means you're holding the bevel horizontally or very close to the endothelium. The same tip, if it is held in the correct angulation, you will find that the bevel is not visible. I call this the bevel sign, and this will help us to find out the depth or the plane at which emulsification is taking place. Very simple. Of course, it works only for straight tips and not curved tips and only, So this is the surgery done by my junior. You can see that she is emulsifying the pieces close to the endothelium because the bevel is clearly visible. And she usually complains of having a lot of striate keratopathy. But the correct way to do it is to angle the phacoprobe in such a way that you're doing the phacoemulsification in the supracapsular space. Then finally, I think we're having some feedback, right? I'll give you am I audible? So I finally give you a few tips on hard cataract management. And this I have seen many surgeons do, that while you create the chop, we have to take the sharp chopper to the depth of the nucleus. So what you do is you just look at the diagram on the top right hand corner. You flex your hand so that the chopper becomes like a paddle. I call this a paddle maneuver. So the sharp tip of the chopper is facing inwards and the blunt tip of the chopper is facing posteriorly. So you make it like a flat instrument instead of a sharp instrument pointing posteriorly. This intuitively happens in many of us, but in case we are not doing this, we can follow. In very hard cataracts, it is critical to remove the central endonucleus core, because you will find that very hard cataracts, you're not able to get a through and through chop. But when you get the central nucleus core, then you can remove it. Finally, instead of creating large lateral separation, you can do this rotational separation. I'll just show you how the rotational separation works. Hold the piece, don't move it laterally, just rotate the piece. And as you rotate it, you will create the separation. This will not put any strain on the zonules and therefore much more safer to the patient. And finally, the most important carry home tip we can take home today is when you're doing the last piece emulsification in patients with hard cataracts. That's when you have that danger of last piece PC rent. Now, in order to prevent this, I always stop the surgery and put in some viscoelastic because it has got a higher viscosity and more drag, and it helps to effectively combat the surge. And this will help me to manage these cases without the risk of getting a PC rent and having a heartbreak and a sleepless night. Thank you for your attention.
Thank you very much, sir. It is indeed a pleasure to look at this new